The characteristic auscultatory finding of mitral regurgitation is a holosystolic murmur of constant intensity, as shown by this phonocardiogram. Listen to a patient with mitral regurgitation. I will start with 3 normal beats and then add the murmur. The constant intensity of the mitral regurgitation murmur is a result of the persistent pressure gradient between the left ventricle and the left atrium throughout systole. This figure shows the direction of this regurgitant flow. This murmur is heard best at the apex, with the patient in the left lateral position. When the regurgitant jet is directed posteriorly, this murmur radiates towards the left axilla. If the regurgitant jet is directed anteriorly towards the sternum, the murmur radiates towards the left sternal edge. Mitral regurgitation will increase in response to hand grip maneuver. Listen to the change in this murmur with a hand grip maneuver. Rest. Hand grip. This murmur extends all the way to the second heart sound, reflecting the significant gradient that exists between the left ventricle and the left atrium throughout systole. Common etiologies of mitral regurgitation include myxomatous degeneration of the mitral valve, as shown in this figure. This figure shows an example of mitral regurgitation as seen by color Doppler echocardiogram. In summary, mitral regurgitation presents with a holosystolic murmur of constant intensity, which is heard best at the cardiac apex. Listen once again to a patient with mitral regurgitation. The murmur of mitral stenosis is a low-pitched, rumbling, diastolic murmur as shown here in the phonocardiogram. This murmur is heard at the cardiac apex with the patient in the left lateral position using the bell of the stethoscope. The presence of an opening snap should alert the clinician to look for mitral stenosis. I will start with 3 normal beats, and then add the opening snap, and then the murmur. Having the patient lie on their left side brings the heart closer to the chest wall and makes this murmur easier to hear. With exercise, the gradient across the stenotic mitral valve becomes larger. When a patient's heart rate is above 90 beats per minute, the diastolic murmur of mitral stenosis can be confused with a systolic murmur because systole and diastole are nearly equal in duration. One way to avoid this pitfall is to simultaneously palpate the carotid pulse to establish the onset of systole. Echocardiography can demonstrate the degree of stenosis as well as the size of the left atrium. With calcific mitral stenosis, the opening snap can be lost, but the murmur remains. In patients with appropriate anatomy, mitral stenosis can be treated by a balloon valvuloplasty procedure as shown here. In summary, mitral stenosis is a low-pitched, diastolic rumbling murmur which is heard at the cardiac apex with the bell of the stethoscope.